Hello and welcome to Onc Now, the podcast that brings you the latest conversations with leading voices in oncology research, innovation, and care. I'm your host, Dr. Jonathan Sackier, and today I'm delighted to be joined by Dr. Stephen Freedland. The good doctor is director of the Center for Integrated Research in Cancer and Lifestyle and associate director for training and education at the Samuel Ocean Comprehensive Cancer Center at Cedars-Sinai Medical Center, where I used to work. His work bridges science and lifestyle, investigating how diet, obesity, and exercise influence prostate cancer development and progression. Dr. Freedland is also at the forefront of addressing disparities in prostate cancer outcomes across racial groups. He's a passionate advocate for treating the whole patient, not just the disease, combining traditional oncology with holistic, patient-centered approaches. So it's a real pleasure to welcome Dr. Freedland to Onc Now. So, Dr. Stephen Freedland, welcome to the Oncology Now, Onc Now podcast.
Thanks for having me. It's a great pleasure to be here.
Fantastic. So what we do is kick off with a few quick questions to sort of ease into it and get to know you a little bit better. So you've trained and worked at some of the most renowned institutions in the country. And as I said in my introduction, my old stomping ground, Cedars-Sinai. What specifically took you into your specialty and specifically prostate cancer? Is there a backstory?
Yeah, I mean, I've always been fascinated by cancer. Not a great personal connection, but it's a scary disease. And I thought as a young kid coming up that I could make a difference, and really became a question of what type of cancer at that point. And going through med school, we've evolved a lot. But back when I was training, the way to cure cancer was surgery. You found it early and you cut it out. So it really became a question of what type of surgeon. And for various reasons, personality, a lot of unanswered questions, I was just drawn to prostate cancer. No, again, great personal connection, but something I've been passionate about for a long time now.
Yeah, well, the institution you work at, of course, an old buddy, Skip Holden, did a lot in that space, absolutely. And I enjoyed collaborating with him on a number of things many, many moons ago. Great place. So give us a diet or lifestyle myth about cancer you wish would just go away.
I would say that probably the best one is the value of supplements. You see all these patients coming in taking lots of supplements and herbs and all these things, and there's really almost no data of benefit of any of them. And there's actually some data to suggest they may actually be harming patients.
There was the classic meta-analysis a number of years ago, I'm blanking which journal it was in, that demonstrated that effectively most of these supplements just make your urine expensive.
Correct.
So,
correct.
Yeah. So, but lifestyle is important in prostate cancer care, right?
Absolutely. No, we're still scratching the surface, still trying to figure it out, and you know it's challenging because there's a lot of, you can't not eat, right? We all have to eat. We all have to eat something, and you want to eat, maximize good food, whatever that looks like, and minimize bad foods. And we don't always agree on what's a good food or a bad food, and foods interact. It's interesting. We talk about lycopene and vitamin D and these different things. They're fat soluble. So unless you're getting fat in the diet, you're not actually absorbing a lot of that. And so you look at the Italian foods and stuff. It is a lot of the pasta and different stuff, but they have all the tomatoes, but it's with olive oil. It actually helps you absorb the nutrients. So it's challenging, because you may have someone who eats a lot of tomatoes, but unless they're eating it with fat, they're not actually absorbing the nutrients. And that's just one example. So it's really challenging to study. That's why we focus more on actually randomized trials to try and get answers. But it's challenging. I think it's really important. I just can't tell you offhand what to do. I have opinions, but I don't have tons of facts.
Yeah. I remember that Michael Milken, when he was diagnosed, talked a lot about changing his diet.
Yeah, no, he went extreme low fat, kind of a vegan, which, there's some data on that, plant-based. My bias has been more towards the keto, low carb side of things, for which we've generated some data as well. And I don't know, they seem diametrically opposite, and yet both may actually be helpful, which is interesting.
A habit that you recommend to all cancer patients and one for all those who wish to avoid developing a cancer?
Yeah, I mean, it's hard to pick one. I think, obviously, not smoking is probably, when we think about lifestyle and cancer, is probably one of the strongest. Beyond that is an obvious one. Try to get to a healthy weight and stay there. It's probably one of the strongest data we have is just obesity linked with it. And then the simple question is, well, how do I get there? And the one thing that we have found is avoiding simple sugars, cookies, cakes, candies, soda. Probably the one thing, both for patients with cancer and those at risk of cancer. If we could avoid those simple sugars, I think we'd all be a lot better off.
Healthy diet, maintain a healthy weight, avoid sugar, and certainly no smoking.
And then try to
A
get some
quick
exercise as well.
Oh, yeah, there you go. Absolutely. It's astonishing, isn't it? How many things, uh, good diet, good exercise. I've just finished writing a book on diverticulosis and diverticulitis for the lay public. And the enduring message throughout the book is if you don't want to be pooping into a plastic bag, drink a lot of water, eat a lot of fiber. That's it, basically, and exercise. So, a quick yes or no round. Just say the first thing that comes into your head. One, is personalized medicine the future of oncology?
Absolutely.
Yeah, how are we going to pay for it? That's the broader question. Maybe we'll get into that. Is genetic risk underestimated in prostate cancer? My dad died with prostate cancer.
I think it is, but I think lifestyle plays a large role as well.
Okay. Can lifestyle interventions be as powerful as some pharmacologic agents, or do we not yet know?
I don't think we know, but I think they can be. We just have to prove it.
Okay. And proving it is trials, and trials are expensive and take time. So, best possible advice at any given time, right?
Yeah. And that's, again, trying to avoid being obese, get some exercise, don't smoke.
Yeah, there you are. So, should prostate cancer screening start earlier in life for high risk groups? And for instance, am I in a high risk group? My father had the disease. He was a smoker.
Yeah, no, I think it absolutely should. We can debate what earlier means, but we've often historically said if you had someone that was diagnosed with prostate cancer in your family, strong family history, start 10 years before they were diagnosed. So whatever age they were, minus 10, that's when you should start.
Okay. Of course, the diagnosis is normally previously asymptomatic rather than screened populations, right?
Historically, if we go way back, correct. So screening changes a lot of things.
Clinical trials, you've already mentioned that, but it's sort of a self-fulfilling prophecy. Diversity in prostate cancer clinical trials. It's a disease that has, and we'll get into this, has some ethnic, racial, socioeconomic indicators, and therefore it's hard to recruit those people into clinical trials. Correct? Or what can you do to
Yeah,
improve
yes
on?
and no. I mean, it's interesting. So if we look at particularly Black people in prostate cancer, 67% more likely to be diagnosed with prostate cancer, over twice as likely to die from prostate cancer. And there's increasing data that suggests when approached and offered a clinical trial, the enrollment rate of Black people is the same as white. And yet, in the clinical trials we see in prostate cancer, just based upon numbers, you would expect if we just took, for example, everybody with prostate cancer in the US, about 20% of them are going to be Black people. And yet, we're lucky if we get 10% of the trial being Black in the United States. And I think one of the biggest challenges is that we tend to do big clinical trials in centers that don't see a lot of Black people. So Black people more often are going to VAs, they're going to county hospitals, underserved hospitals. That's not where the majority of the clinical trials are housed. So I think we need to build the infrastructure, support those institutions, and make sure that those people get onto the clinical trials, because all these great advances we're having, and we're having a lot, we need to know that they work for all of our patients, not just the white patients.
Yeah, absolutely. Well said. So let's do a bit of a deeper dive, Stephen. You've spent years researching the links between lifestyle and prostate cancer. What's the current evidence telling us about diet, obesity, and physical activity and how they affect risk and progression? So you've hinted at it. Go into it in more detail on diet, obesity, and exercise.
Yeah. And so, incident prostate cancer is very challenging because by far the biggest predictor of being diagnosed with prostate cancer is screening. So any factor that predicts screening is going to predict being diagnosed. So in many of the studies, we don't look at just being diagnosed. We look at being diagnosed with aggressive prostate cancer or dying of prostate cancer or having the cancer and progressing. And so when we look at that, the classic kind of bad lifestyle factors play out in prostate cancer, and that's smoking and being obese. Physical activity, little harder. There is some evidence, I would say less clear, that physical activity being good. We certainly know it's good for the heart. We know it's good for many, many diseases, just less clear in prostate cancer, but certainly something we recommend to our patients. So I think that's the data. The challenge is, okay, we don't smoke, we should exercise. I shouldn't be obese, but how do I get there? What do I actually eat? And that's where it's there's no clear cut answers. Again, there is some data about healthy eating, defined kind of loosely, avoiding simple sugars, avoiding processed foods, more fruits and vegetables, having benefits. But at the same token, there's a little bit of data emerging that extreme low carbohydrate diets, which tend to have very little fruits and vegetables, very high meat content, may have benefits as well. So it's not a clear cut picture in terms of what to eat. And if you got 5 people in a room, you'd probably get 6 opinions about what exactly the right thing to be doing. But again, I think we can agree avoiding simple sugars, processed foods, avoiding being obese, getting some exercise, don't smoke.
Yeah. One of the things people talk about, the Mediterranean diet, right? And the presence of lots of tomatoes in conjunction. I was just in Italy and did some cooking classes, and everything starts with olive oil and tomatoes, seemingly everything, which is fantastic. But surely you have to take into consideration that the genome of the population may be different. Maybe people who are born and bred in the Mediterranean, their diet, the way they interact with their diet is different. So you can't apply just one factor. So, you're mentioning a low carb diet, a high carb diet. How do you pick apart those factors?
Yeah, and it's challenging, and also just the way they eat in Italy is much more social. It's a family affair. It's slow eating. It's just a very different environment. And so there are a lot of observational studies in the U.S. and Europe where they've asked people, "What do you eat?" and try to track it. But it's hard to understand. People don't eat foods; they eat a pattern. You eat multiple foods at the same time. So it's hard to isolate one food. Things have kind of moved to patterns. We're actually working with several of the leading people in the field on a review article that's hopefully coming out soon about dietary patterns and prostate cancer. And you mentioned the Mediterranean. That actually probably does not have the strongest data, despite what you may think. And so there are like healthy eating index and different things. And about half the studies show benefit to those, but half really don't show anything.
Yeah.
And so again, it's really hard to come up with clear answers. I do think we need a lot more randomized trials in this space. But if you do a drug trial, you get adherence 99% to the drugs. You can track who takes it, who doesn't. With dietary interventions, we're not even close to anywhere near that. So even if you had the
Yeah.
perfect diet, if people aren't adhering to it, are we going to see as great of benefits as we could have? A lot of challenges. It doesn't mean we should give up. It just means we got to work harder.
Yeah. My guess is that AI will play some role in helping us pick apart these data points. And your comment about the Mediterranean diet, that wonderful work on the blue zones, which I believe shows um, only a 4-year benefit for those living that kind of lifestyle. But the thing that blew me away when I first looked into this was that loneliness, social interaction in many of these communities is a huge, huge part of lifestyle, whereas in the West it isn't. And that loneliness was a major factor in predicting early morbidity and mortality.
Exactly, and that's why I say that they eat in a social setting. It's slow. It's family meals, and that probably has more impact and benefit than necessarily what's on the table.
Mm. All right. Well, we've mentioned racial disparities. You've been a leading voice in highlighting this in prostate cancer outcomes. What are the major contributing factors here, and what can we as a medical community do to change that trajectory?
Yeah, it's a great question, and what concerns me in the realm of racial disparities is I don't think we're treating our patients equal or equitably. So when we develop new imaging modalities to find the cancer better, whether we have new drugs to treat the cancer better, they're not being used equitably. And this is based on data in the US, but I think it'd probably be similar in other places. And particularly higher socioeconomic, particularly white patients are getting earlier and better access to those treatments. So, in a way, we're improving care for prostate cancer, but we're doing it more so for some groups than others. And so, we're actually creating more disparities as we get better at caring for cancer. So, and we see this, for example, within the VA system, where there's equal access. We see outcomes as a function of race are actually equal between black and white. And if any thing in certain circumstances, the black patients are actually doing better. So I do think we need better access to care across the country. We need better access to the latest, greatest therapies and treatments. And I think if we did that, we could level a lot of the playing field. We'd still be getting a lot more cancers, prostate cancers, in black people as opposed to white people. We don't fully understand that. Is that a function of systemic racism? Is it stress? Is it socioeconomic? Is it diet? Clearly, some sort of social determinant of health that we haven't fully captured. So we have a lot of work to do, but I think just providing equal access, equal treatments would go a long way to minimizing some of these differences.
Right. Yeah. It is, as always, a complex issue. And your point about the hospitals that in America, the Veterans Administration or county hospitals, it calls for the need to have multi-center trials and make sure you're inclusive. One area that's this fascinates me. One area that's overlooked in mainstream discourse, and I've obviously it's been in the news constantly for the last 10 years or so, is prostate cancer among, and I want to make sure I phrase this carefully, among those who are born with an XY genotype who undergo what I believe you call gender affirmation treatment. What do clinicians need to know about this population and how their risks may differ? So these are, when I'd originally phrased this question, it was men who undergo sex change, because I'm a simpleton. But there's complexities to this. So
Yeah. So
please take it on.
yeah, no, and this has been a lot of learning for me. So the proper terminology is transgender women. These are women. That they identify as women, and that's what they are. They are women, and they were born, as you say, with an XY chromosome, and so that's why it's transgender. That the chromosomes don't match their gender, um, And these, transgender women can undergo often gender-affirming hormone therapy, which is typically estrogen, which causes castration. Testosterone goes super low. They can undergo varying degrees of surgery, removing the testicles, sometimes removing the penis, putting in breasts, making neovagina. But what's interesting is no matter how much surgery is done, the prostate is never removed. So you have women that are women that look like women. They are walking down the streets. They are women. That's all you know. You're the physician. You see a woman walking into your office. You would never necessarily, unless you really took a history and talked to them, know that they still have a prostate and that they are at risk of prostate cancer. And so I think that's kind of the biggest misnomer, is that during gender affirmation surgery that the prostate is removed. That is not true.
Really, really challenging. I once had a patient who referred with a hernia, but it was this lady was a true intersex and had been brought up as a girl, and she'd not had surgery, and it was actually a retained testicle.
Yeah. And there's a lot of intersex type thing, but these are, people that were anatomically what we may consider male, but clearly identify as women. And what's interesting is, typically we screen for prostate cancer by doing a PSA test. So what's really not well appreciated. So let's say you did understand that they are transgender, you did understand that they had a prostate in place, and you ordered that PSA test. So you're trying to do the right thing, screening for prostate cancer. But PSA is actually a gene that's controlled by testosterone. So if you have a transgender woman who's taking estrogen with or without having removed the testicles, testosterone is super low, the PSA levels will be super low. So what we call abnormal needs to be adjusted. And we actually published a paper last year in JAMA that said the median PSA value in transgender women on estrogen is 50-fold lower than the equivalent of a cisgender man, similar aged, 50-fold lower PSA levels.
Can there still be a trend upwards, but you wouldn't note that it's high? As you say, you need a second scale. And I presume is that data available? Are those data available?
Well, that's what we're trying to generate is I do think PSA would be very sensitive. It's just the level that we call abnormal would need to be adjusted. And the challenge is we don't necessarily know what that correct number should be, but that's research that we're trying to do.
Okay. So switching gears to therapeutics, enzalutamide has become a cornerstone in advanced prostate cancer care. What are you most excited about with recent trials or data involving this agent? And I have to say, if I've mispronounced the drug, that's totally in keeping with me, because I have a mental block with all these drugs. I cannot pronounce any of them.
Yeah, no, you pronounced it correctly, enzalutamide. So what's exciting to me, and I think I'm a little bit biased because I co-led the trial with my dear friend Neil Shore. But B, it's the latest, I think, exciting data on enzalutamide, and C, it is, I think, revolutionizing care. Is, historically, when patients got surgery or radiation, remember we talked about PSA. That's how we diagnose prostate cancer. Once you treat it, the PSA should be 0 or near 0. And as the PSA starts to rise after treatment, it's a sign the cancer is back. And historically, we would just wait and wait and wait until that PSA got high enough, the patient had metastatic disease, and we would treat them. We always wanted to treat them earlier. We just didn't exactly know how or when. And so we did a study called the Embark study, supported by Pfizer and Astellas, and I'm a consultant to both companies. And we said, let's treat these patients with standard hormonal therapy, or standard hormonal therapy plus enzalutamide, or enzalutamide alone. And what's exciting is 2 years ago, thereabouts, in New England Journal, we showed that we could delay the progression of the cancer by adding enzalutamide to standard hormonal therapy. And what's super exciting is literally 4 days ago, there was a press release that actually showed that treatment within the Embark trial actually improved overall survival. So we actually allowed patients to live longer by adding enzalutamide to their care at this really early stage of cancer recurrence. So super exciting. We can delay the progression, we can make patients live longer, and we didn't worsen their quality of life for these asymptomatic patients. So it's pretty exciting.
Excellent, excellent. Um, Another therapeutic question for you. Recent data on various radioisotopes, for instance, FDA approved lutetium PSMA conjugate as a therapeutic modality for prostate cancer. I think I saw it was an abstract on the impact in castration-resistant men with metastatic prostate cancer. Is this the long-promised silver bullet?
I don't think it's the magic silver bullet that's going to magically cure our cancers. There, so this is a drug that combines some radioactivity to a molecule that goes and finds the tumor cells and delivers that radioactivity right where the tumor cells are throughout, usually the bones, but wherever the tumor cells are. So in theory, it sounds great. And this magic bullet, as you say, um, it was first tested as kind of a third line therapy in castration resistant prostate cancer, showed a survival advantage. It was tested in the second line, showed benefits, recently approved by the FDA. And most recently, we've seen a press release that in men with newly diagnosed metastatic disease, so they haven't had any treatment for their metastases, and are just starting hormones, starting another drug like either enzalutamide or similar, adding this drug, lutetium PSMA, improved and delayed progression. We've yet to see those data publicly. There was a press release. So I think it's like many drugs we have. We start in the late stage, we move earlier and earlier. I don't think this is going to be the magic cure that people had hoped for, but I do think, like many drugs, going earlier and earlier could have a greater impact. And I'm excited to see where this can go even earlier. Obviously, we want to see the data from the press release for sure, but future where are we going? I think for many of these drugs, earlier really is better. And historically, we said, well, I don't want to use my best drugs early. I want to save them for late. I'd rather use my best drugs early and hopefully we don't need them late. That there is no late, we can prevent that. So that's the
Yeah.
goal, and we're starting to see, again, some pretty impressive survival advantage from using these drugs early.
It's interesting that newer drugs tend to be more expensive than older drugs. So there's a natural resistance on the part of healthcare systems to pay for them and reserve them for the later case. But of course, if you do a detailed health economic analysis, you discover, oh, if you hit the cancer hard early, as you say, they may not have a recurrence. And you can actually save money in treating the disease rather than paying for the drug. So,
Absolutely. And in the US, we tend to be pretty unaware of costs. I mean, the patients are certainly very aware of it, but as providers, we don't always think about those costs. But I know certainly in other countries, that's a huge issue. And you get drugs approved by the EMA, which is kind of the European FDA, but countries won't reimburse it until they go through a whole economic model, and the countries and the companies work together to decide what is the value of the drug, what are they willing to pay for it. And it's a negotiation. Whereas in the U.S., we do things very differently. So it's interesting working with the Astellas and Pfizer on enzalutamide and seeing that process of the drug being expanded labels, rolling out in different countries, learning about the process. Very, very interesting.
yeah, it truly is. Um, And I don't know that there's one right way of doing it. I've worked on both sides of the duck pond. I just wish we could all get together around a table and say, hey, in this country, they do this thing very well. Why don't we adopt that instead of pointing fingers at each other? Stephen, you've been deeply involved in medical education and mentorship. What advice do you give to young oncologists who are entering what is a rapidly changing field? And I think about the changes in oncology in my professional lifetime. So, if you're mentoring a youngster getting into the field, what do you say?
Yeah, it's a great question. And I think first and foremost, one of the questions I like to ask my people is, are you having fun? You got to enjoy it. Life is hard. It's a lot of stresses, particularly in this era right now, a lot going on in the world, but you got to find something you're passionate about. And, you can make all the logic in the world of why studying this disease or that disease makes sense. But at the end of the day, you got to enjoy it. You got to really delve into it and enjoy it. And if you enjoy, it's that classic thing. If you love what you do, you're never going to work a day in your life. This is not work. So you got to find your passion. Within that, I think the other thing, the advice I give is it's a different world. It's a team sport these days. This myth of this genius who sits in the lab by himself and creative genius coming up with all these ideas. It doesn't happen. Ideas are cheap. Everyone has great ideas. It's the hard part is actually implementing them, doing the trials, doing the studies, and it takes a team. So understand, what role are you going to play on that team? I'm sure, and you could have many equivalents of soccer. In America, we tend to be a football. It's funny. You want to be the quarterback, but you got to have a receiver to throw to. You need a running back. You need someone to block for you. You need someone to kick the extra point when you do make the touchdown. What role are you going to play on that team? And particularly for the clinicians, to me, that role is being the clinician, understanding the disease, being in the clinic, seeing the patients, understanding the questions that they ask. And you got to be able to speak other people's language. You got to know enough about the statistics, enough about the basic translational stuff, but you don't need to be the expert. So again, know your lane, know how to communicate with others, but respect others and let them do what they do best. And at the end of the day, have fun. Work with people you like. There's plenty of people in this world I love working with, and there's some that I don't. And you try to work less and less with those and spend more time with people you like. And at the end of the day, you got to enjoy what you do.
Yeah, graciously said, Stephen. There's over the years that I've been doing these podcasts, talking to so many people who have had the sort of career you've had, clinician scientists, people who, in the world I was working in, minimally invasive surgery. One of my pals at Cedars was constantly talking, railing against, quote, academics. And I used to wind him up and say, my dear chap, you're an academic. I know that you don't have a full-time teaching position, and I know that you don't hold an NIH grant, but you've got a curious mind. You're asking questions. You're conducting the research. You're communicating what you found to your colleagues in an honest, transparent, and engaging manner. That's academic medicine, and that's why it's so fulfilling, right?
It is. One done right, and you go in with that mindset, it's very rewarding. Absolutely.
So I've got a final question for you before we let you go. Love to ask our guests that if you came across a magical genie, and I know you happen to be near a beach at the moment, you're walking along a beach, you kick a bottle, out pops a genie, offers you 3 wishes in your area of healthcare for the future of prostate cancer care. What do you wish for, Stephen?
Yeah, I mean, honestly, it'd be great if we had a magic cure that no one got prostate cancer or suffered from it. But trying to be a little bit more realistic is one, if we could just have equitable care. We're making great advances, but not all of our patients are benefiting equally. And that's very disturbing to me and something I'm very committed to try and fix. So equitable care. Um, I think related to the lifestyle, I really want to know, what is the role of lifestyle? And can we come up with, whether it's your genotype, the tumor makeup, your microbiome, your personal preferences of what your taste buds are like, culturally sensitive, that we could design a personalized diet lifestyle for you and that actually made a difference for the cancer. I think we can as someday get there, but I would love to have that sooner rather than later. And I think, and we are working towards this. And I think we do pretty well in prostate cancer, but I think, we need to reduce the side effects of our therapies. And if we had therapies, and this is why I'm so passionate about the lifestyle stuff, that actually didn't have cardiac side effects, didn't have fatigue, didn't have other side effects that can really impact the quality of life of our patients. I think we're doing pretty well in prostate cancer, but it doesn't mean there's not opportunities to do even better. So less toxic, more effective therapies given equally, and lifestyle showing its impact as sometimes alternative therapy, but often as a complementary therapy.
Well, I know that you have taken time from a family vacation and it's very late where you are. I can't thank you enough, Dr. Stephen Freedland, for being with us, for sharing your knowledge, and for everything that you are doing to help men deal with this wretched disease and your passion for it. So we're going to let you go and spend time with your family. Maybe you should go for that walk on the beach. Stephen, thank you.
Get some exercise for our men and our transgender women. Absolutely. This has been great.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.